It's not connected. Okay, now it's back.
Good afternoon, welcome. I'm Wayne Miller with the Providence Journal, and we are here at the Brown Medicine Sleep Center. And we're going to be talking for the next several minutes, up to an hour, about sleep and difficulties in getting to sleep and things you can do about that. And so this is going to be a nice, wide-ranging discussion. We have joining us Chris Ruzzo, who is a registered sleep technologist here at the center, and we have Dr. Katie Sharkey, who is a national expert on sleep and sleep disorders, researcher and clinician. So we're in good company. Katie, you wanted to say a few introductory words?
Yes, sir. So we're so excited to be doing this and partnering with you, and really happy about everybody's interest in sleep and sleep medicine. And I know we're going to be fielding a bunch of questions that people have called in or submitted online. I do want to point out that none of this should be construed as me giving medical advice, because I haven't had a chance to interview or take histories and physicals from the people who wrote into you. So everybody should check with their docs or call and make an appointment with us, and we'd be happy to see you individually. But I don't want to be practicing medicine over Facebook Live.
Right, and we don't want you to be doing that either.
Great.
So this will be informational, and in setting this up and leading to this, we solicited questions, and a number came in by email and by phone, quite a few in fact, and we'll be getting some additional questions during the next hour. So here's one that came in by email. Can you please ask your guest, Katie Sharkey, about the impact of sleep on adolescents? Specifically, can you ask her what recent data has shown that the movement to shift school start times to later in the day? Katie?
Sure. So I think that's a great question. This is a debate that's sort of taking health and science into the public landscape and into the public schools. And we know that sleep is an important thing for adolescents in terms of their behavioral regulation, safety, decision-making, brain development. And the data throughout the country show that school children from middle school and high school ages don't get enough sleep compared to what the recommended amounts are. Just a word about the recommended amounts: they are derived from how much kids sleep get healthy sleep-wise when they're brought into the laboratory and allowed to sleep their duration that they do naturally. So that's where those numbers are derived from. When you survey kids or measure kids, they don't get that amount of sleep that we think is required. And so the change in school start times is really meant to be a way to address this as a public health problem, because at the same time that kids aren't getting enough sleep, as they go through adolescence, they're usually in a school system where middle schools and high schools start earlier. And science from researchers like our very own Mary Carskadden, who's at Brown University, and other colleagues have shown that the drive to sleep, so the amount of sleepiness buildup across the day, starts to slow as children go through normal adolescent development, and also their body clock gets a little bit delayed. So that results in them not necessarily being as sleepy as they would be at their ordinary, say, 10-year-old bedtime. 14-year-old probably can't fall asleep at the same time that they went to sleep when they were 10. And so the idea of changing the school start times is to allow for them to get adequate sleep and to be sort of obeying their own natural biology by delaying that time that they have to be up to go to school. We know that when that happens, children generally have better grades, better mental health outcomes, better safety. So there's a study done in Kentucky where the students, they looked at car crashes in the counties that changed school start times versus not, and showed that the adolescents were involved in fewer car crashes. And when you think about, these are brand new, inexperienced drivers, there's a lot of public health evidence suggesting that school start times is a good way to manage the overall public health problem of teens not getting enough sleep at a critical period in their human development.
Certainly is an ongoing and often controversial debate in this country, and indeed in Rhode Island. A number of our questions concerned sleep apnea and treatment of sleep apnea with CPAP. So why don't we just very quickly get a definition of what sleep apnea is. Katie, we can do that, and then Chris, you can talk about some of the remedies and specifically about CPAP. Been a lot of interest. So what is sleep apnea?
Great. So sleep apnea, which is a form of what we call sleep disordered breathing, is when the throat closes off while people are sleeping. And so if I were to say, open up and say, it's right back there in the back of your throat, and it would just,
We're not going to do that here.
No, but no practicing medicine on Facebook. But it's not a lung problem, it's an upper airway problem. And when people are asleep, and even more specifically in REM sleep where our muscle tone is decreased, that the throat can close off repetitively. So we routinely see sleep studies where people stop breathing hundreds of times a night.
Hundreds?
Because it can happen. There's sort of a theoretical limit of about 120 times per hour, like more than that, and you can't measure it, but hundreds of times per night. And the problem is each time that throat closes, the oxygen goes down, the brain wakes up. And so there's two problems then. One is the next day problem. So if I just tonight took anybody and woke them up once a minute, they wouldn't feel so good the next day. It's sort of like sleeping on a train or an airplane. You think you're kind of asleep, but really you can hear the beverage cart go by in the aisle or whatever. So it's that light sleep. The next day they don't feel so good. And then the other thing is we know that, night after night after night. So the studies that we see where someone's stopping breathing once a minute, every night's like that for them. And so we know over the long term, that nightly exposure is bad for your heart and your lungs and your brain. So things like stroke, heart disease, pulmonary hypertension are all associated.
So it's not just a question of you're feeling fatigued or tired the next day.
There's the next day effects and then the long-term
effects. Which are actual impacts on health.
Oh, for sure. Yeah. Exactly.
So Chris, you run the lab here. Talk about what you do.
Okay, so once somebody has been diagnosed with sleep apnea, and there are various testing procedures to come up with that diagnosis. It all depends on the health provider, which is the best way, and that is coming in for a sleep test, whether diagnostic. Some of our patients take what we call a home sleep apnea test home with them. It's just a one night, pretty easy.
Equipment.
So,
here, I'll hold the box if you want to come back over here.
So the home sleep apnea testing, because of certain situations, whether patient insurance-wise, it's not necessary to come in for an attended study, okay? What we do is the patient will come to the sleep lab. We instruct them how to apply this mobile unit here. It's totally wireless, so it's got a little belt. There's only a few sensors, and we go over everything so the patient, before they leave, they are comfortable. It's pretty much an extension of the sleep lab. They just don't go home and we give them the device and say, have a great night, we'll see you tomorrow. They have a 24/7 hotline. They can call me at any time here during the night. So it's just like an extension of the sleep lab. Just a little easier. Again, because of patient necessity of not wanting to be here, or again, sometimes the insurance requirement. But when a patient...
But that's a great device for people
it
who
is a
might
great
not,
device.
I've had patients who say, there's no way I'm ever coming to the sleep lab.
Right, it's a great tool.
And so that's good because then we can get those people in. They get them to get studied
So you can do it at home, but some people do
Correct.
come to the sleep
Yeah.
lab.
Yes,
Now,
they do.
Let me just make a point here, because when I started writing about this, and the story hasn't appeared yet, but it will soon, I heard sleep lab, and of course I think Frankenstein. And I was very surprised to see what the sleep lab actually is. And so what is it?
So the sleep lab is basically, it is a bedroom. We try to really maintain a non-aesthetic type of laboratory that, that this kind of stigma with a sleep lab is a lab-related type of room. It's a bedroom. It's a full or queen-size bed. All the comforts of
more
your
like
own
a
home.
hotel room
A
than a
hotel
hospital
room,
room.
absolutely.
Do you have room service?
Yeah, well, I'm hoping
No,
to do
but
that
when the
for me in
Patriots
morning.
play, we order pizza.
Yes, I've done that on patients.
That's important.
It was important because they were very upset that they were here for a sleep study. So we ordered takeout pizza and everything was a great night. So, so they come in here, we try to make it as comfortable as possible. We like to acclimate to the room to be comfortable, wireless if they want to read, and just try to mimic a window of what they usually do every night. So,
I actually have patients that tell me that they slept better in the lab
Yes,
than they sleep at home.
I think,
and I always say
that,
no, but I think there is this aspect of they think maybe they're anticipating it's going to be worse than it is, and then also you take care of everybody and put them such at ease that once they're here, they don't have to think about anything. They also think the wires are going to be worse than they are.
So the expectation that they're coming in with this lab setting And when they see the room, they're very pleasantly surprised. Then I do come in at them with say, well, we're going to put some wires on you. And it is a wired type of testing. That's, the gold standard, the best way to diagnose, and everything is monitored so the physicians can review this the following day. So it's important that, definitely explaining before anybody comes in and knowing what they're going to be undertaking. And they're, again, pleasantly surprised. They didn't think these wires were, not going to be all in their faces and hanging everywhere. We pretty much try to keep everything so it's not in view. That's the most important. And hopefully it's a good night for them.
And what do you monitor? The wires go to some kind of technology that tells
Yes.
you what?
So I'm looking at a monitor. If anybody's been into like the hospital setting where you're in a room that's monitored with a post-anesthesia unit, an intensive care, an ER. You have these nice monitors by the bed that have all vital signs. So once all these wires are, applied, I'm watching these monitors in a control room. Vital signs, brain waves, movement, everything vital to what is going to diagnose. Everything has to kind of pinpoint and go in the direction like this is the diagnosis. This is sleep apnea. It's not something we sit there and say, well, we can look at this. It's diagnosed.
We're looking
everything's
like
there.
for
It's
every 30 seconds.
documented.
We're looking in 30
30-second
chunks
pages. It's
at brain waves.
It's a complete recording of the entire night. So everything is there. So again, when the doctor reviews it in the morning, I'm trying to make it like they're there all night with me. So because there is a video, and again, some people get a little freaked out when they see there's a camera monitoring all night. It's literally a 2x2 screen. Again, it's for not only for the safety, but sometimes things go bump in the night, and there's different types of sleep disorders. Again, the physician needs to see that, know what I'm trying to relay back to them in all my notations all night long, but again, it's all relevant to the diagnosis of what people are coming in for.
So one of the emails we received was from Tim, and he began by writing, "Sleep is the biggest problem in my life," and I'll paraphrase the rest, but he has trouble getting to sleep and staying to sleep. He's been diagnosed with a sleep medication. He doesn't watch TV or use his phone before going to bed. He's 30 years old, describes himself as fairly active, good diet. What should he do? Is this a candidate for a sleep study?
Sounds like it. If he is sleeping, thinks he's got no other health problems.
That appears to be the case, yeah.
But wakes up feeling tired the next day. Is that what it says?
Yeah. And what can I do to help to stay asleep throughout the night?
So I think that we want to make sure that there isn't an undiagnosed sleep disorder. A home study like Chris was talking about will record and look for sleep apnea.
Yeah.
A lab study would also look to see if he has something called periodic limb movement disorder, if his brain is waking up multiple times a night because of some intrinsic problem. If we don't find anything on a sleep study, somebody who has insomnia, we can recommend other treatments for them.
Okay.
But the number of sleep disorders that go undiagnosed, I think, is very high because either the bed partner is asleep and can't report it, or there's no bed partner, or the person just isn't aware that they're having a problem. I mean, when I go over the sleep studies with patients and I show them, you stop breathing once a minute and your oxygen goes down to the 50s, they have no idea. They don't know if they could, because most people, if they knew their oxygen was going down to the 50s every night, they'd come and do something, right? Yeah.
Might be a little bit alarming.
Then I have their attention, right?
Yeah.
So it seems obvious, but like to say it, people don't know. If they knew, then they would do something about it. And so when somebody like that who doesn't have another explanation for why he feels so sleepy and why he's waking up, I would want that person to get an assessment.
So we're talking about sleep apnea, and there is a treatment, CPAP. CPAP stands for?
Continuous positive airway pressure.
And I think, again, this goes back to sort of the preconceptions I had, not knowing very much about sleep research. I had in my mind the image of a Frankensteinian, one of these big things from 20 years. A ventilator, something as big as a person, him or herself. Not the case.
Oh, sure.
What do they look like now?
Not the case. So, one of the interfaces, that's the politically correct word, because it really isn't a mask, when
Mask,
you look
right.
at it. So, this is what the device is. This is a pretty much, it is a sample of a CPAP machine.
That's
Okay?
small.
Small, and this is actually made for women. It's to be a little more pleasantly to look at. But it
also
does
has
have
different algorithms.
It has an
in it.
algorithm that tries to mimic, our natural breathing. Because women, opposed to men, are a little different when it comes to that muscle movement. But this right here is a sample of what one of the interfaces. This is what we call nasal pillows. There are
What's it
folks
called
out there. Nasal pillows.
So these are the pillows.
They fit
It's
into those.
even got a cute name.
It does.
Well,
there are
it's got a
patients-
sleep-related name.
Well, it's
Yeah,
better than a
it has
mask,
to.
right?
Exactly,
Yeah.
because there are people that just don't like having anything on the face. They whether it's claustrophobic or they just have a type of skin irritation. The way the masks fit, it's not a one size fits all. Absolutely not. If anything, and anybody has used CPAP in the past, uses it, the key is the mask. This has to fit. If this fits comfortably, everything else will work in place. It doesn't matter which device. It'll all work, but this has to be the comfort zone. So this is great for people that, they are mainly nose breathers and less on the face. You could actually be a belly sleeper with this. It's not, you
Really?
don't have to lay there and just be stiff on your back all night. We do make you do that in the lab sometimes because we want you at yours. And no one's going to be in there elbowing you to wake up or turn. But this is the least. We do have masks that cover mouth and nose for the fact that some people just breathe mostly through their mouth. So,
Although
it's all
I think
comfort.
people can learn to breathe through
Well,
their nose.
yeah,
sometimes
they're
I think
supposed to be
yeah.
nose breathers.
Sometimes I think those full face masks are a good training mask.
Yeah.
So
It
people
is.
have been
It is.
keep sleeping with their mouth open, try to get some air in, and once they're getting their sleep disordered breathing, they
Yes.
can learn.
Right out of the gate, a full face mask is great. Sometimes that full face mask can actually be a little adherence because you've got this air, your mouth is wide open. I'm trying to keep your airway open and
Your mouth closed.
closed, and now we're pushing this air, which could be pushing some of that tissue back again to the back of the throat. So absolutely positively a nasal system. But again, we do all that here.
And-
You come
and
in
that's
here and we
key.
habituate everybody.
That's key is that they're 40 masks. So if at first the don't succeed with the mask, then and it also highlights I think why having experts do this, Wayne,
Yeah.
is so important because they'll be able to help people work with what's the right mask.
It's almost
So
like going to a shoe store and
absolutely.
getting the right size and right
frankly,
shoe.
I use that shoe analogy all the time
Really?
because
Yeah,
no, I
you just
swear.
said that? Wow.
No, I'm not
Look at that.
because
She's a lot of
sometimes
analogies.
yeah, but sometimes you go into a shoe store and you think you have bought the right pair of shoes, and then you walk around
Yeah.
for them for a few days, and you're like, oh, really, that hurts my arch, or gives my big toe with a problem, or whatever. And same thing with the masks. I mean, people are going to go home with the mask. They'll work with Chris. They'll find one. They think it's great. They sleep with it one night. Great. 4 days later, that it's rubbing their face or it bothers their nose.
Okay, so you come back
And so yes.
unlike
So
some
you
shoe
would
stores where you own them, you come back and
yes. So usually within 30 days we can do a mask switch out, and that makes all the difference. I would say probably at least half of my patients don't end up with the mask that they start with. Because we want to make sure that it's really the right one, and I think people have trouble when they are starting with a new thing to learn which is the right mask.
It makes total sense. Now, one thing that you have found, both of you have found in your work, is there is a disparity between women with sleep apnea being diagnosed and men with sleep apnea being diagnosed. Meaning, more women have sleep apnea that do not get a diagnosis than men.
Right.
Talk a little more about that.
Sure. The estimate is that 90% of women with sleep apnea go undiagnosed.
Wow.
I know. And we think that 24% of men, the estimates are that 24% of men and 9% of women have sleep apnea. So,
I mean, of the
the
general
population. So, and as a rule of thumb, 7% of people have asthma. So it's
a lot of people.
It's a lot of people. And that gender gap also closes as women age. So although it may not be directly related to menopause, as women get older, they catch up to the guys. So it's 24 versus 9% is from age 20 to age 60 or 70, but it equalizes as
That's the
in
prevalence,
in
but
middle
the
age.
diagnosis
Correct.
disparity persists.
Yes, the diagnosis disparity persists, and I think that's because women are more likely to be, complain of different things, so they're less likely to say they're loud snorers. I don't know if you feel like women snore less, or maybe they just don't like to report that they snore.
They don't like to report it, but when they're hearing the sleep lab, it's definitely
You're hearing the
reported,
snoring.
and, yes, and the doctor can hear them.
But women are more like studies have examined gender differences in the reporting of symptoms, and so men are more likely to report the loud snoring or say that there's a bed partner who complains. Men are less likely to complain of mood or cognitive complaints, and women are more likely to complain of those. There's some evidence indicating that women are more likely to get put on an antidepressant or an anti-anxiety medication when they report symptoms that turn out to be sleep apnea. So it's the reporting is different, and then how the symptoms are interpreted by the clinician are probably different. And then there may be barriers to women coming to the sleep lab too. I mean, I think there are many women who don't know that they're going to get a nice lady who's going to be the one taking care of them, and their idea, it's back to your Frankenstein comment, right?
Yeah.
How many people say that they're like relieved that it's you?
Yes, because it's a woman here, and it's so it's a female, but a lot of these women do say that it's, it's a social, it's just society. Like, they are too busy. Like they've been a caretaker, and now they're in their late 50s, and it doesn't, they have time to really look at their own symptoms and how they're feeling. But for a long time, it's just they just didn't have the time.
Or their sleepiness got attributed to I'm a mom, I'm a wife, I'm taking care of my parents, I'm taking care of my kids, I'm working, and so it's not only the inattention, but the idea that it would get attributed to something else.
You can associate it with something different, and again, if if you went to your healthcare provider and they said, well, it's a little antidepressant. Any woman I feel over is 45 needs one of these in their medicine cabinet type of thing, and so it does. And then, but when you get tired of being tired, that's the key. That's just the key.
So we're going to be writing about one woman who has sleep apnea and the difference CPAP makes. Talk about in general the difference before CPAP, after, in terms of being tired, in terms of your outlook on life, in terms of life being better, for lack of a better term. What happens?
You hear them.
What's the difference?
Well, you hear them the next day. I mean, the next day.
It's a wonderful thing when somebody wakes up and they're like, I just feel like I slept. I just slept the whole night. They actually, they felt the love the next day. Doesn't always necessarily, like, we're looking at perspective. I'm looking at, as far as clinically what went on, and it's just a major change of what I saw on their diagnostic recording to their treatment recording. It's a really significant improvement, and they do wake up and it's like, I don't feel like I'm in a fog.
Right.
I feel like I can, because the first thing I'll ask is, how do you feel? Do you feel okay to drive? And they're like, I absolutely feel like wonderful. I feel like I woke up literally not like, can I just roll over and hit the snooze button again? And that is, it's a win-win.
So and that fog state pre-treatment can be dangerous. I mean, you hear stories of people driving to work who are nodding off at the wheel. They roll the window down, trying to stay awake, doesn't work. They forget, they wake up and, oh my God, I'm here at work, and what did I go by?
The time went by, right? Exactly. I think
that's dangerous, right?
For sure, dangerous. So absolutely. The problem is when you're so sleepy that you're nodding off or fighting to stay awake, then wakefulness is not stable at that point. We're starting to uncover the neurobiology of sleep and wake, and we know that as people get more sleep deprived, or if their sleep is fragmented, like from sleep apnea or another sleep disorder, that the brain can't maintain the stability of wakefulness. In other words, when you're awake and driving an automobile, you want to be all the way awake. And then on the other hand, when you're asleep, you want to be all the way asleep, which is the problem people have with sleep fragmentation, insomnia, and stuff like that. But while you're driving and that sleep is encroaching, your ability to maintain wakefulness becomes you can't depend on it anymore. Nobody who crashed their car falling asleep behind the wheel thought they were going to, or they would have pulled over, right?
Yeah.
I mean, and they say, oh, I roll down the window, or I turn up the radio, or drink cold water is a good one. And those last for maybe about 30 seconds. But after that, the sleepiness will overcome those.
And it's
measures.
not a question of willpower. It's like if I will myself
no.
to be awake, I'll be awake. And this is something in the biology of the organism.
This has been studied in high accountability professions, like in the cockpit. I have a colleague who worked for NASA measuring microsleeps in the cockpit of pilots.
What's a microsleep?
Oh, a microsleep is when during wakefulness, the brain waves show a little brief episode of several seconds of sleep. And, it's the when you're late at night having a conversation with somebody and maybe they like zone out for a minute, what their EEG might show is that they were in light sleep at that time. So
wow.
They're beginning to disengage from the external environment. And it can be brief, but that can overcome people. So that's been shown in airline pilots. It's been shown in anesthesiologists giving anesthesia in surgical settings. I mean, to try to understand like what does sleep prevent? What can we overcome and not overcome? The PSA here is don't drive while you're sleepy. Please pull over. Get caffeine or get rest.
So why, speaking generally and historically, why has sleep not been seen for what it is, which is a vital part of keeping the organism healthy, right? This isn't just a question, well, if I get good sleep, I'll feel better. You're going to be better. Your health is going to be better. Why was that ignored or maybe it wasn't a question of ignoring, maybe it just wasn't known. I mean,
I think some of it is that it
learned.
wasn't.
The unknown. Yes,
unknown.
The unknown, and it was always attributed to something else that may have been going on in your life at the time. It was, years ago when I started in this field, most of our patients, I worked in the hospital, say for the emergency room, and they came in more of a cardiac problem as opposed to sleep. And it was like, oh, well, this was kind of precipitated by a sleep disorder that went untreated for years and years and years. So,
and the field of sleep medicine is really new, Wayne.
Yeah.
I mean, you have to remember it was the 50s when they were discovering REM sleep.
It was that recent.
Oh yeah,
relatively recent.
1950s.
Wow.
I mean, so some of
the
fathers of sleep medicine are still alive and and seeing patients and teaching.
Yes, they
so CPAP wasn't a viable option until the early 80s. Yes, where you could have it, and then they were much bigger and louder and so forth. But
years ago, BiPAP or
we
CPAP was
we
to
didn't
prevent
know.
something.
We didn't know. We didn't have anything to treat the disorders. And then, I'd also like to say there's this sort of macho, tough culture that, that we really need to, I think, start to back away from. So, starting from the time you're a kid, you get punished. I'm going to send you to bed, like that it's a punishment to get sent to bed early. Or that, if you,
so
how
there's a cultural bias.
Were you allowed to stay up late and watch a TV show, from the time you're an adolescent, that those things are it's a reward as opposed to then when you're our age it's like a reward if you feel like you got an 8 hours and then you feel like you got a reward. But there is this like toughness and that I think has promulgated lots of industries into our culture a lot, and now we're starting to see the flip side of that where people are respecting sleep more. You see that in corporate America, like that people say I don't want to get emails from you at 3 a.m. Or people will not send things in the middle of the night because it's sort of becoming frowned upon, like, why are you working?
Good, should be.
Agree.
So Christine wrote in, hello, I have tried many over-the-counter products. I have tried Ambien and Trazodone. I meditate. I have tried acupuncture. I have a sleep sound machine. I have good bedroom hygiene. No computer, nice and dark, comfortable temperature. I've tried deep breathing exercises. You name it, I've tried it. Nothing works. I have difficulty falling asleep and staying asleep. If I get 3 hours at a time, I am very fortunate. I am very anxious to hear what Dr. Sharkey will suggest. And again, we're not giving medical advice.
Right.
So this is Maria Caprizzo, off-camera digital editor at the Providence Journal, and I'm monitoring the questions that we're getting from our live Facebook audience during this conversation. And so since we have some that are in the same neighborhood with what you've just asked, let me add those in. And I know that Dr. Sharkey doesn't want to do any medicine on Facebook, so feel free to not answer these questions. But one person says, which are the best natural remedies that can support sleep? Another person says, how much sleep should an adult be getting at night? And another person, and this may be a little bit further from the topic that you just asked about, Wayne, but does dreaming interfere with or support sleep?
Why don't I answer the insomnia one first, and then maybe we can come to dreaming, because I think dreams are incredibly interesting, but a
Separate.
little bit, like you said, separate.
Thank you.
So, what this woman who wrote in, it sounds like she's experiencing what we would define medically as insomnia. So that's the problem where you either have trouble initiating sleep or staying asleep or wake in the morning feeling unrested despite the opportunity to sleep. And, there are pharmacologic and behavioral treatments. And so that goes into your natural remedy question, Maria. The data show over and over again that behavioral treatments for insomnia are really the ones that last the longest and are the best treatments, at least first line to start with. That's not to say that some people don't do great on medications, and that's always a risk-benefit conversation that you have with your clinician, but there are some very specific techniques that can be used and can be delivered with a psychologist or a sleep medicine professional. So, and we have some great ones. There's a great behavioral sleep medicine group at Lifespan. There are other practitioners in the community that do behavioral sleep medicine. So and that's called cognitive behavioral therapy for insomnia, or CBTI. And that focuses on, like it says, behavioral and cognitive approaches. So the behavioral approaches are to make sure beyond sleep, so it goes beyond sleep hygiene. And it goes into something else you said, Maria, which is how many hours of sleep does somebody need? So I would say one of the most common things that I see when patients are having insomnia is they're so tired that they end up saying, I'm going to get home, I'm going to eat supper, I'm going to get right into bed. And so, it might be 8 p.m. and they might plan to get up to start their day at 6 a.m. So that's 10 hours in bed. The adult human brain can really only make 7 to 8 hours of sleep. Like your brain can only make 7 to 8 hours. And so if you're climbing into bed thinking, oh, I'm going to drift off, between 8 and 9, and I expect to wake up at 6, there's too much time there for your brain to fill with sleep. And so I would say one of the first parts of that cognitive behavioral therapy for insomnia is to reduce the time that people spend in bed. So it's called sleep restriction. And when that's done in conjunction with a sleep therapist, they'll sometimes reduce it quite a bit. They can go down to 4 or 5 hours where they'll only let you spend that much time in bed, and you're supposed to keep busy and plan what you're going to do and stay awake and not go to sleep until you actually feel like, when I get into bed, I'm not going to be able to resist going to sleep. And so, it's not until the person sort of fills up that whole five hours, say, with sleep, that then you say, all right, well, I'm going to give you another half hour, and you can go to bed a half hour earlier. Usually the morning time is the stable time because people have to get up and get going. So those are that kind of technique is the behavioral part, sort of restricting the time that people spend in bed. Of course, doing some of the sleep hygiene stuff. So, but although patients come a lot to me and say, I know I'm not supposed to have my dog in there. I know I'm not supposed to have the TV on. And again, then what we do is, but they'll say, but I don't think that's causing my problem. So then we can do a little experiment. We can say, all right, well, you came to see me, you bothered to come. Let's just try it without, Rover in the room for a week and see if it's better. Or, try to work out why is it that the TV has to be on at night. Then sometimes you uncover PTSD or some other thing that makes people want to have, there's something else going on that that the behavior that they're doing that's impinging on their sleep, there's something else that it fulfills. So you start to unpack like what's really going on at night. And then the cognitive part of cognitive behavioral therapy is to try to get people to stop worrying about it so much, because in these typical kinds of insomnia cases, the sleep disorder takes on a life of its own a little bit, and then these are people who, by the time they're getting into bed, they're thinking, oh my gosh,
they're already angry.
Here I go again. Right.
I can see that.
Getting nervous talking about it, right? And that's how they feel, or they've spent, they're worried about how they're going to pay for the million thread sheets that they just bought. So they've bought into the sleep industrial complex, and they're worried about that, and how come I can't sleep? I have a new mattress, and they get themselves so worked up. And then I think some of it's also the expectation that us older folks have, that they're maybe going to sleep as well as they did when they were in their 20s, and they're not. So like, it's normal to get up and go to the bathroom and for it to take 10 or 15 minutes to fall back to sleep. And the key is to sort of not let people's mind get carried away from that. So in patients like, what's her name? Christine,
yes.
that I would say that, you know, depending on her age and other symptoms, that's somebody who might deserve a sleep study, since like we said, 90% of women with sleep apnea go undiagnosed. Can't tell from that. But then the other thing would be to engage in cognitive behavioral therapy for insomnia. And there's actually, so some people, there's a really good book that I recommend to some people too, called the Insomnia Workbook by Stephanie Silberman. So it's a really nice one. It's got different chapters about, you know, what to do if it's the beliefs about sleep that kind of get you going, and how to keep a sleep diary so you can kind of see what your pattern is, that kind of thing.
So I think what I'm hearing from both of you is, in a lot of cases, these issues don't go away on their own. You need some type of intervention, be it reading a book, be it seeking, you know, medical, you know, professional help. Or is that not true?
Yeah, because sometimes you don't know the direction of the patient's problem. So could be insomnia? Is it a obstructive sleep apnea? There's something. So sometimes just, you know, peeling the layer away. But definitely talking to a healthcare provider and a sleep specialist, because you just don't know, again, what direction that they're going in or coming from.
Right. I think this field used to be sort of viewed as like a lifestyle medicine, or kind of not a real medical field.
Kind of groovy.
Sure,
like,
exactly.
It's
still come on, it's still groovy, but
in a good way.
In a good way, but that it didn't have health impacts. So you know, now we know that atrial fibrillation, there's sort of no point in getting, that's something that they'll shock you out of, or that they'll give you medications to convert when you have an irregular heart rhythm and atrial fibrillation. If you have sleep apnea and you have AFib, until you treat the sleep apnea, it's sort of, there's no point to try to treat the AFib, because
Really?
it just makes the atrial irritable, and it'll continue with that arrhythmia. So we know there are medical concerns with this. The other thing, though, I want to say is these are treatable. That's the best part of my job, is that people get better with this. You know, you can get somebody's insomnia better. The cognitive behavioral therapy for insomnia, there are several giant controlled trials in, you know, young people, in older adults, showing that it works, and that it works better than medications, and has a longer impact. You know, so they study these people a year later, and they're more likely, if they went through the 6 or 8 weeks of therapy, to be a better sleeper a year later than on the pills, which come with, like we were talking before we recorded, their own set of concerns, like hangover effects or odd behaviors during the night, that kind of thing.
So this is sort of a medication related question. It has to do with melatonin. We had a number of questions about melatonin. Let me just read.
Sure.
This comes from Mary, who signs her email Happiness, Joy, and Laughter. At age 50, I started menopause, and my sleeping through the night started to change. I fall asleep, but I can wake up anytime between 2, 3, or 4 a.m. I have tried 2.5 milligrams of melatonin, reading, a meditation ed, and so on. I am now 69, and I need my Beautyrest. I teach meditation and let your yoga dance. I am my own boss. I married the love of my life 48 years ago. Any suggestions? And again, we're not going to get into, you know, doses of medication,
Sure.
but what is your suggestion sort of in general? Or what do you think about melatonin?
So that sounds like somebody that I would say would be a good candidate for this cognitive behavioral therapy for insomnia, just to sort of pick apart, is there something we could do with her schedule? Regarding melatonin, so melatonin is a hormone. It is low during the day, and it goes high a couple hours before bedtime, stays high during the night, and comes down in the morning. It's secreted by a gland in our brain called the pineal gland, so it's in the middle of our head. Basically what the pineal gland and what melatonin do, melatonin tells the brain, hey, it's daytime, and when melatonin goes up in our bodies, it is transducing the fact that, hey, it's nighttime outside now. So until melatonin goes up, it's pretty hard for people to fall asleep. In fact, the circadian clock, our internal biological clock, controls the secretion of melatonin from the pineal gland, and it's opposing sleep before then. So you know the second wind, like somebody says at 4 o'clock you want to go out to dinner, and you say no, And then at like 9, somebody goes, "You want to go see a movie?" And you're like, "Sure." So that second wind is kind of the very tail end of your biological clock's signal to keep daytime going. But once that dissipates and melatonin starts to rise, it's permissive for sleep. The brain knows it's nighttime. So that's all what the body's own melatonin does. Now you can buy melatonin in the United States over the counter. It's classified as a health food supplement here. It's classified as a drug in Europe and other
Really?
countries, so you can't get it without a prescription. Melatonin has been shown to have both sleep promoting and body clock shifting effects, and the body clock shifting effects are stronger than the sleep promoting effects, so, which means that if you're taking melatonin for night shift work or to combat jet lag, that those effects are stronger, and that's because people are typically taking that melatonin at if they're a shift worker or have jet lag at a time when their own pineal gland hasn't made any melatonin. Does that make sense? So it's giving the signal on a flat surface. When people take a melatonin supplement at bedtime, most likely their own melatonin has started to be secreted by the pineal gland, and so they're just sort of adding to what is already there. In some patients, that's still helpful as a sleep promoter, but if you think about the way we think that receptors work, so this is the melatonin molecule going into the melatonin receptor, it's already, you may take a pill, but if your own melatonin is already being squirted out, that receptor's filled up already. So in some patients, maybe they don't make enough melatonin, or a stronger signal is better for them. But when patients come and tell me, "I tried melatonin at bedtime and it didn't work," it doesn't surprise me, because it's probably that they're already making their own melatonin. Does that make sense?
It does.
There are
does,
the
absolutely.
other group that I'll say that benefits greatly from melatonin and melatonin agonists is patients that are blind. So if you don't have a light-dark signal because you can't see, those melatonin from those helps those patients because it gives them something to hang on to. Does that make sense?
It does.
Great.
Mary used the term Beautyrest, and we had beauty sleep, Beautyrest, and before we went live, we were talking about the effect of poor sleep deprivation, and how you physically look, and you made a joke. Somebody named Ed made a comment.
Yeah, Ed wanted to know if sleep deprivation makes you ugly, and it turns out that there's some evidence to suggest that that's the case. So
I mean, we don't look as attractive.
Don't look as attractive. So there's a group and nobody likes to be on the receiving end of the you look exhausted. Like anybody's out there, just truth that comment to yourself, right? Like no one needs to hear that. On the other hand, we've all viewed people that you think to yourself, boy, that person looks exhausted. And so there was a group in Sweden that took a bunch of people and sleep deprived them. And they took pictures before and after, and then since they were doing this other sleep experiment anyway, they just shot the photos of them before and after. And then they had another group rate them the sleepy, with an intermixture and a counterbalance and all this stuff. And the people who were sleep deprived were not rated as physically attractive. And it's also been done, there's a group who even specified further for all the sleep apnea fans out there, especially because sometimes the sleep apnea patients worry about the marks on their face from the mask. Mm-hmm. But this was a study that was done at Michigan. Ron Shervin led this study, and he measured attractiveness in OSA patients, sleep apnea patients, before and after treatment with CPAP, and they were rated as more attractive after treating sleep apnea. So, yes, sleep deprivation can make you ugly.
Fred wrote in right before we went live, what causes dry mouth and thirst? What can be done? He says that this makes him, he wakes up about every 2 hours thirsty, dry mouth, has to get water, and waking up every 2 hours, of course, is not an ideal way to sleep.
Yeah. So this is a CPAP user?
He didn't specify whether he was or not.
Maybe.
Well,
I think he might have mentioned if he were, so I'm going to guess he's not.
Okay.
Okay, so if he's not using CPAP, he probably is a mouth breather all night, because whether it's sleep apnea, a little obstruction, upper airway, his mouth is open to compensate that closing of his airway. So he's just
trying to suck in air.
So
anyway.
it's just the mucosal membranes are
correct,
just trying.
Because we're put together as we have a built-in humidification, purification up here. So if you're bypassing all this and you're a big snorer and the mouth's wide open, you're going to wake up with a very dry mouth, because the air going to your lungs now is a little bit, it's cooler, it's dry, and as it hits those airways, think of it as, you got dry, brittle hair in your hair as you go out into the cold, and your hair it's just dry, and it just feels crunchy, and it's, your airways, you've got this warm air going down, because you're snoring, it's going down those airways, and it's kind of like banging off of those nice
Right,
soft
that's what the snores are.
That's what the snore is, and your lungs don't like that. It's very harsh. So you got that nice big snore, and you're gonna wake up with cotton mouth, and
Other things that come to mind with dry mouth. So sleep apnea, definitely. Sleeping with the mouth wide open. Medications.
yes,
Another
medication.
another dry mouth thing. But then the other thing that we see a lot when sleep apnea is treated is people then no longer have to get up a million times to go to the bathroom, because of course this is a vicious cycle, right? If I don't want to do it because it's not pretty, but you're doing this big snore with your mouth open, you're dry, you glug a thing of water, then 40 minutes later you got to get up to pee, and then it's this constant cycle. So I would say it's not the most common symptom, but it's up there where people say are relieved that the symptom is relieved once we treat them with CPAP.
Yes. Now,
is they're not getting up to use the bathroom and their mouth isn't dry, because the
So
machine has a humidifier.
Yeah, these
Oh, it does.
these have a humidified and climate control tubing. This is a very generic tubing, but right here is the humidifier. So if he's specifically saying, well, he's a CPAP user waking up dry.
So water goes in there.
Just regular
and
water?
No, distilled water.
Distilled water,
Because it gets
okay.
all crusty
Okay,
if you don't
yeah.
use your distilled water. It gets, like the minerals and stuff dry up, because this gets, or
Lime,
they condense,
hard-
right,
hard
exactly,
wa-
hard water,
yeah.
because this gets warmed up and then
There
gets
is a-
blown in through the
a tubing,
tube.
which the tubing is also climate controlled also. So it's
There's a little wire in it to keep
it's a
it warm.
heated tubing,
in
keep
the
it a little
tube.
warmer, so kind of mimics our own natural breathing as far as when we're breathing that nice warm air in, if you were breathing upper airway. But if he's on CPAP, and that was his question of dry mouth, this is adjustable. It can be adjusted to your own. There's humidifier settings, increase, decrease, cool, heated, all about preference.
Can you add aromatics to that too?
Yeah, no,
Okay.
you shouldn't.
No
Yeah.
lavender.
No,
unfortunately,
In
that's
the
just
room,
a
but if that's what you're.
This is why I'm not
up
a
for.
doctor. See, I would add lavender.
No,
Yeah,
you
you
wouldn't.
wouldn't want to do that.
I would think of adding lavender.
I'm glad. No, we would say don't do it.
Okay.
Yes, not to that. No, you don't want to breathe in all
Because you don't
those
want to breathe
oils.
in the oils and stuff like that. Once
Then
they're
you
in
have
your
no
lungs, it's
problem.
hard to get them out. But yeah.
So, Kevin writes in, I am a 67-year-old male who has sleep apnea.
Mhm.
I have been using a CPAP for 15 years or so. I currently sleep soundly for 4 to 5 hours per night, no matter what time I go to bed. So sometimes I'm awake at 3, 4, or 5 a.m., and I lie there waiting to fall back asleep, which takes time. Back in my college days, I would have difficulty smoking a joint or even be in a room where pot smoke was, as it would make me very sleepy. I missed the end of many a good party, snoring on a pile of coats in the bedroom. With the legalization of pot as a, quote, medicine, would using it be a benefit to me to achieve a deeper and longer sleep? So it's basically a question,
Should I use
Just-
marijuana?
should I use marijuana to sleep better?
Yeah, I wish I knew the answer to that, is my answer to that. Because the research, that we need more research. I mean, I don't think marijuana is going away. But as a medical practitioner, it's not something that I feel comfortable recommending at all
Yeah.
right now, because the research that's been done on marijuana is done on strains that, you can go into a shop or a dispensary or, in places where it's legal, and there's a marijuana expert, and they can say, oh, this is good for your joints and this is good for this and so forth. And I believe that they may believe that to be the case, but I want to see the scientific evidence for that before I feel comfortable as a clinician, prescribing it. And a lot of times the marijuana that's out there in the world isn't even available to researchers. So this is an area where politics and science are bashing up against each other, and there's a reluctance of the government to say, yes, you can do this research, but at the same time people are using it, and so now we have these people doing something, and the docs get asked it all the time but don't have the data to answer it.
Okay.
So it's frustrating.
I think we have reached the end of our session here, as it were, and I want to thank Chris and Katie for joining us and being very informative here. we'll be having a story in the journal shortly in more depth about many of these topics, and look forward to it. For Providence Journal, I'm Wayne Miller, signing off.